Hello students. We are going to talk about today the hypertensive disorders of the pregnancy. This is the part 2. In the part 1, we have already discussed about what are the other spectrums of the hypertensive disorders of the pregnancy, which includes the gestational hypertension, where you do not see any kind of the end organ damage or you do not see any kind of proteinuria. It is just going to be raised blood pressure. Next, we talked about was the preeclampsia, which had the evidence of the proteinuria or the end organ damage along with the raised BP. Now, if you extend this spectrum, okay, so once the damage, end organ damage to the, if the CNS is involved, what happens is the along with the raised BP, there is a damage to the CNS taking place. There is a lot of edema inside the brain tissue which is occurring. All this will lead to the hyperexcitability of the brain tissue, and ultimately it generates the development of the convulsions in the body of the patient. Okay, so this is going to be called as the eclampsia. So this is one of the major complication of the eclampsia which is seen, and most of the times this eclampsia is going to be preceded by the preeclampsia. Okay, so we are going to, in today's this section, in the part 2, we are going to talk about the eclampsia. And lastly, we will be going to discuss about the chronic hypertension. That is, those women who are already they are hypertensive and they conceive. So that is the last section we are going to talk about. Okay, so let's begin with this. So here, first of all, we will be beginning with the eclampsia. So what is eclampsia? As I already mentioned, it is derived from the Greek word. So as I mentioned, what exactly is eclampsia? So it is one of the word which is derived from a Greek word, which means it's a Greek word which means flashes of the light. Okay, flashes of the light. So here there is occurrence of the tonic and the clonic convulsion or the coma in a woman who is already into hypertensive. That is, already she is going to have preeclampsia, and also you cannot tell that this causing of this tonic convulsion or the coma is because of any other cause. So this is for sure that it is the preeclampsia which is going to cause such kind of the tonic clonic convulsion. Now, this patient is going to have signs and symptoms. So what happens is that there is a patient who is having, how is she going to present? So she is going to have, either she is already a known case of the preeclampsia, that is raised blood pressure. Along with that, there is sudden worsening of the preeclampsia which is taking place, which might cause the damage to the other different organs, like liver might be damaged. It is going to produce the subcapsular hematoma because of the stretching of the Glissen's capsule. The patient is going to have the sudden epigastric pain as well as the pain in the left hypochondrium, or the patient is going to experience vomiting because of the same complaint. Okay, so these are the two features of GI tract. The patient might also, because of the sudden development of the cerebral edema, especially in the case of the occipital region, or because of the retinal hemorrhages, patient is also going to complain of the scotoma or the amaurosis, that is blurring of vision is the complaint which patient is going to tell. Or because of increased intracranial tension, patient also tells us that okay, she is experiencing the throbbing kind of the headache, okay, which is not relieved by any kind of the, it is not going to get relieved by the painkillers. Okay, so these are the signs which are going to be seen in the patient who has the episode of eclampsia. And if you go for the history, ask the relatives, then she might also, the relatives might tell that okay, she was experiencing before 4-5 hours, she was experiencing this complaint. Along with that, you might also see that there is sudden worsening of the edema. Either the patient will be coming with the complaint of the generalized edema, anasarca, or there is edema in the extremities, as well as the vulvar edema would be seen, as well as the signs of the urine. You will see the worsening of the proteinuria. So all these are seen in the case of the patient with the history of the or the episode of the eclampsia. Now here the problem with this is that it is going to, since the brain is going to get affected, there is very high morbidity as well as mortality. For a patient, it is going to be almost as high as 4 to 6%, mainly because she undergoes unconsciousness and there is damage to either the there might be aspiration of all the gastric contents into the respiratory tract because she might develop coma, or there is damage to the kidney as as well, leading to the development of the renal failure, which might be tubular or the cortical necrosis. Apart from that, the more importantly what is damaged is the blood supply of the fetus, because what happens is that during the episode of this kind of the tonic clonic convulsion, what happens is uterus is undergoing to go sudden kind of the spasm. Okay, so uterus undergoes sudden spasm, and because of which at that particular moment the blood supply to the uterus and the placenta is going to be momentarily stopped. Because of that, fetus is going to experience hypoxia, and ultimately what you see is the perinatal mortality in as high as 45% of the cases, which is nearly going to be one half of the cases. Okay, so that is why if it occurs in the antenatal period, the fetus is one which is going to be damaged and more at risk of damage. Okay, now if you talk about the etiopathogenesis, so the etiopathogenesis in this case of the eclampsia is going to be same as that of the preeclampsia. Okay, so if you consider a timeline, what happens in majority of the cases, if here at this particular stage she is going to have the eclamptic fits. Okay, somewhere if you go trace back in time, majority of the patients are going to have preeclampsia. Okay, and as we all know that in case of the preeclampsia, you have the two-stage hypothesis where there is abnormal placentation. Okay, abnormal placentation with the abnormal trophoblastic invasion into the spiral arterioles. Okay, these spiral arterioles are not converted into a capacitance vessels, and what happens is inside the placenta there is going to be hypoxia, which causes the release of the inflammatory markers. These inflammatory markers go and act on the system, and it is going to lead to the abnormal endothelial damage in all the vessels of the body, ultimately leading to the increased capillary permeability. Okay, this causes the edema. Okay, edema, which is also seen in the case of the cerebral tissue. Okay, so brain is also affected. Here renal, there would be glomerular endotheliosis which is seen. So all the organs, you have this increased capillary permeability as well as the damage to the endothelial lining, which might cause the damage to the platelets as well as the lysis of the RBC, producing abnormal coagulopathy. Okay, so because of this brain which is affected, it may excite all the neurons, ultimately causing the development of the tonic clonic convulsion. So underlying mechanism in such a condition is going to be the similar to that of the preeclampsia. Now, if you consider the type, there are basically three types depending upon the timing in relation to the delivery. So majority what happens is, if it is occurring whenever the patient is still having the baby in the antepartum period, the incidence is going to be as high as 50%. Okay, intrapartum during the labor it would be as high as 30%, and lastly you have in the postpartum period it would be 20%, which occurs within the first 2 days, that is going to be 48 hours of the childbirth. Okay, if a conversion is occurring after 7 days, then there are very less chances that this could be because of preeclampsia. It can occur in the puerperium, but up to the 6 weeks, but it still is very rarely you can tell it that okay, this conversion epileptic fit is because of the eclampsia. Okay, now what happens is, as I mentioned, that preeclampsia is going to precede the development of the eclampsia. So there are also signs which have been developed, that is the signs of impending eclampsia or imminent eclampsia, because of which where you are going to give the prophylaxis for the eclampsia, as a result of which you are going to give the magnesium sulfate, which is also used for the prophylaxis of the eclamptic fit, and therefore the incidence of the antepartum eclampsia has been decreasing compared to that which was seen previously. Okay, so here these days what happens is that, let's say a doctor is sitting in the periphery, in this, let's consider in the peripheral health center, and the patient and relatives come, like the relatives come with the patient. They tell that okay, she had history of the eclamptic fit, and she has not yet had the features of the eclamptic fit, but she is developing signs of the headache or blurring of vision, or there is sudden epigastric pain or vomiting which is projectile, then what you need to do is you have to, if a doctor is sitting in the periphery, after measuring the BP, you find that okay, the BP is going to be raised is somewhere around 170 by 110, you just, along with the antihypertensive, also you give the prophylaxis for the eclampsia, that is magnesium sulfate, which will help in prevention of the future eclamptic fit. Okay, so that's why that is one of the major strategies which has been used these days, and as a result the incidence of the antepartum eclampsia has been declining. Okay, the other term we have here is the intercurrent eclampsia, which means what? So once a patient has the episode of the convulsion, she will be recovering from such an episode. Okay, so patient is going to recover, and then pregnancy also continues for more than 48 hours after her eclamptic fit. That is going to be called as the intercurrent eclampsia. Okay, next you have is the atypical eclampsia, which is the eclampsia or the fits which is occurring before 20 weeks of the gestation or after the 48 hours of the postpartum, which is going to be very rare, and this is actually something which is atypical, and that is why it is called as the atypical eclampsia. Okay, now you have why exactly does a convulsion occur. So basically we got to know etiopathogenesis, that okay, this is one of the problems which are the extension of the etiopathogenesis of the preeclampsia. But once this preeclampsia has been set in a patient and there is large number of the increased capillary permeability into various vessels, along with that there is a decrease in the oncotic pressure. So these two factors in conjunction, they are going to cause the abnormal regulation in the case of the CNS, and they are going to cause the convulsion. So why exactly does this occur? So as you can consider in this picture, what happens is that, let's consider this is the vessels which are supplying the brain tissue. There is increase in the capillary permeability, because of which what happens is there is increased number of the cerebral edema. Okay, so this cerebral edema will also cause the hypoxia. Also these vessels might rupture, it may lead to the cerebral hemorrhage. Okay, so it can lead to cerebral hemorrhage, and all these can cause the cerebral dysfunction. Okay, this is ultimately going to cause the dysrhythmia in the brain, and the neurons of the CNS, they are going to experience dysrhythmia, and this is going to initiate the development of the tonic-clonic convulsion. Okay, apart from these factors, we have other disseminated intravascular coagulation as well as the derangement in the clotting mechanism. All these are going to add to the development of eclampsia. One thing you need to note is that it is not because of hypertensive encephalopathy, as unlike the patient who is going to be non-pregnant with the raised BP. Here, increase in BP per se does not lead to the development of convulsion. Rather, only thing it would be leading to is the development of the, rather it is not even associated with the development of retinal hemorrhages, exudates as well as papilloedema. So here it is only because of the increased capillary permeability leading to the cerebral edema and the irritation of the neurons causing the dysrhythmia. These are the causes why the episode of the fits is taking place. Okay, next you have is, as I already mentioned, that the signs and the symptoms of the preeclampsia are going to precede the development of the eclampsia in most of the cases, and therefore the patient who is coming to the emergency department with the episode of the convulsion may have the history of the preeclampsia. Okay, now what are these signs? So it is very important in a case of the severe preeclampsia, you should always ask these patients leadingly, despite, and even if these patients are admitted in the ward, you have to advise the staff nurse that okay, always go for checking these signs. So if you consider a patient, you will always see either the patient is because of the continuous cerebral edema, patient may have the headache, okay, which is going to be severe and persistent and not relieved by the analgesic medication. Okay, then if the patient might also experience the blurring of the vision, or she may have the projectile vomiting, or she may have the epigastric pain. Okay, there would also be, if you ask about her, there might also be decreased in the renal output. Okay, or sometimes the patient might have the marked diuresis may also be seen in the variant cases. So all these signs are the prodromal signs of eclampsia. Sometimes patient may also have the brisk deep tendon reflexes. Okay. Next, how is this epileptic fit going to be? So initially, the patient is going to have a premonitory stage wherein the patient is going to have either some kind of abnormalities. She is going to have either twitching of the face or twitching of the tongue muscles, or any kind of, she is going to feel that a hyper this premonitory phase is going to last for roughly 1 minute to 4 minutes. Okay, and then there might be even rolling of the eyes. After this premonitory stage, she will feel that something abnormal is going to happen. Okay, so in after this premonitory phase, what is she going to experience is the tonic stage, which is going to last for around 15 seconds to 30 seconds. Okay, in this tonic stage, as per the name suggests, the patient is undergoing to go the sudden contraction. Okay, so it's a phase of the sudden contraction of all the muscles of the body. Okay, which includes the contraction of every muscles of the body, and the patient is going to have the increased tone with the flexion of the limbs. Okay, apart from that, the tongue muscles are also going to, the muscles of the jaw are also going to be contracted, and the breathing ceases. This is only going to last for around 15 to 30 seconds. After this is done, the patient is going to have a stage of the clonic. That is, there is alternate relaxation, contraction, followed by the alternate relaxation. And in this phase, what happens is, because of the contraction and the relaxation, the patient might, even the muscles of the jaw are going to be strongly, vigorously contracting, and as a result, patient may experience the tongue bite. Okay, there is, along with that, there is uprolling of the eyes. Okay, so that is going to be seen in the case of the tonic stage of the conversion, and followed by the clonic stage of the conversion. Next, you have the stage of the coma. So in case of the stage of coma, this is going to be the last stage where all the muscles undergo, the patient is going to become unconscious. Okay, and she might even not remember that any of these events took place before the development of the coma. And this is the stage which is at maximum risk, because there is since all the muscles are undergoing relaxation, what happens is there is risk of the aspiration. Okay, lastly, you have a condition of the status eclampticus, which is different from the status of the status epilepticus, wherein despite giving all the medication, there is sudden succession of the fits which is occurring in the patient of the eclampsia. Okay, so that was about the phases. Now you need to always rule out that there are certain other differential diagnoses why the conversion is occurring in a pregnant woman. So of them, most importantly, you have either there is patient is having the history of the epilepsy, or she was a known case of the hypertensive disorders with the hypertensive encephalopathy, or she had the cerebrovascular accident such as the stroke in an endemic area which is having the raised prevalence of the malaria. You should always also go for the peripheral smear to rule out the development of the malaria. So cerebral malaria would be one of the reasons. Then you also need to ask the patient if she had history of any kind of the intracranial neoplasm or not, or there was any kind of infection with the infection of the meninges or the encephalitis. Lastly, you also need to go for the measuring the level of the glucose, and if the patient is on the induction, then there might be occurring of water intoxication because of excess amount of the oxytocin diluted drips, or the patient might have the history of hysteria or the cerebral venous thrombosis. Okay. Now, because of this, what happens is, because of such kind of episode of the convulsion, the patient undergoes, there is sudden cessation of respiration for about 30 seconds to 1 minute. And what happens is that there is sudden contraction of various organs. Along with that, various internal organs are going to undergo the hypoxic injury. Okay, so what happens because of that? Which are the organs which are going to be affected? So consider with the development of the all, you should always start with the hematological system, wherein you have RBCs which might undergo the lysis. Along with that, the platelets are going to be damaged. Okay, and you might see the coagulation profile. Okay, abnormal coagulation profile would take place. All these is going to incite the development of the DIC, that is the disseminated intravascular coagulation. Okay, apart from that, if you talk in a systemic manner, what happens is, in the lungs you might see the pulmonary damage. So pulmonary edema might take place, or there is aspiration which is going to cause the damage to the lungs. Okay, in case of the kidneys, you might also see the development of the acute renal failure. Okay, and which is going to be more of the tubular necrosis. Okay, sometimes it can also be acute cortical necrosis. Okay, then if you are going to talk about the heart, then you might also see the myocardial infarction in such a case, or there would be development of the left ventricular failure. Okay, so acute left ventricular failure might develop. In case of the liver, there is, because of hypoxia, what happens is the damage to the liver takes place with the raised liver function test, which is may also contribute to the development of the HELP syndrome. Okay, lastly, you have the neurological defects. Okay, so that was all about the different organs which are undergoing injury in a case of the eclampsia. Because of this, the mother is going to be at increased risk of the maternal mortality, mainly because of development of the cerebral hemorrhages, as well as the lung getting involved, leading to the pulmonary edema or acute renal failure or cardiac failure, or development of the embolism, as well as the postpartum shock. The fetus is at risk of death because it is going to experience either the fetus is going to be premature, or there is intrauterine asphyxia which is taking place, or there is trauma which is occurring to the fetus. So how are you going to manage such a case? So this every doctor who is working in the periphery must know that how to manage a case of the eclampsia, as well as this has to be, you have to know how to manage such a case. Okay, so there are basically few principles about how you're going to manage such a case. So first is, since it is an emergency condition, you need to first stabilize the patient. Okay, stabilize the patient. Next, you should know that, okay, what is the cause of the seizures. So once you know the cause of the seizures, you have to control the seizures. Okay, you also know that BP is one of the causes, so try to maintain the BP and to normalize the BP. And then lastly, ultimately, we all know that placenta is going to be the one which is actually responsible for development of the raised blood pressure, in turn the development of eclampsia. So you have to go for the termination of the pregnancy. Okay, so here the only, you have to go for early detection and timely and appropriate management. That is the key for managing such a case. Okay, so firstly is the immediate management. So once a patient is coming to you, you have to confirm that, okay, this is a diagnosis of eclampsia. You have to rule out the other possibilities, whether you have you are thinking of the cerebral edema or the glucose level falling or any other causes of the convulsion. So just confirm that it is going to be a case of eclampsia, measure the BP and proteinuria, and then shift, if you are in the peripheral unit, that is the the PHC or CHC, you have to shift the patient to the tertiary care center where all the facilities are available, and along with the during the shifting the patient, either some doctor or the staff nurse has to go with the patient in the ambulance. Okay, whenever you are shifting the patient, at that point of the transfer, you also have to go undergo certain basic things to initially stabilize the patient, as well as give the prophylactic dose, or give the initial dose of the magnesium sulfate. Okay, give the therapeutic dose and not with the prophylactic dose. Now there are, if you talk about the management protocols, okay, so first is the general care to the patient which has to be given. The second is you have to give the anticonvulsant in the form of the magnesium sulfate. Third is going to be giving the maintaining the blood pressure into normal range, or lowering the blood pressure to the normal range by giving the parenteral agents like labetalol as well as the hydrolazine. Avoid oral agents. Why? Because patient might have the second episode of the convulsion, and patient might tend to, if you're giving something into the GI tract, the patient might tend to aspirate such contents. Okay, and last principle is going to be the management of the labor. So if you're talking about the general care, so what is it including? Okay, so in general care, immediately shift to the patient to the room where the patient should not hear any kind of noise, because again, if she hears noise, this might actually again cause the second episode of the convulsion, as well as try to keep her in the dark room, because avoid photophobia as well. Okay. Next, you have to go for airway assessment. So put an SpO2 probe to the patient, check the level of the SpO2, as well as you have to go for the, if the mother is going to have the frothing around it, just go for removal of all the froths in the around the mouth by using a suction tube. Okay, clean the airway. Okay, so you have to go for regular suctioning of the airway. Next, to prevent the further aspiration of the content, just you have to turn the mother's face in the left position, that is the left lateral position is given to avoid the aspiration of further content. Now there is a possibility that the second fit episode can occur, and when this occurs, there are chances of the tongue bite. To avoid that tongue bite injury to the tongue, you have to go for giving the mouth gag to the patient, or put at least something between the tongue and the teeth. Okay, so this will prevent the damage to the tongue. So mouth gag or the tongue blade is put to avoid the tongue bite. Okay, and lastly, based on the level of the SpO2, you either give the oxygen and with the face mask to the patient, or if needed, higher ventilatory support can be given in conjunction with the anesthetist call. Okay. Once that is done, you have to go for the intravenous fluid. Okay, so go for the large bore IV. So large bore IV. Simultaneously, once you're inserting that intravenous line, okay, intravenous catheter you are inserting, you also have to go for collecting the blood samples and send it for running for the hemoglobin, where you check the level of the hemoglobin as well as the platelet count. Along with that, you go for running the blood bleeding time and the clotting time, coagulation profile, which includes the PT, INR, fibrinogen, D dimer levels as well. Okay, and you go for even running the renal function test, like measuring the level of the creatinine as well as the electrolytes. Okay, and you assess the liver function test, which includes the bilirubin as well as the serum, the SGOT, SGPT, as well as the levels of the LDH. And lastly, you check the urine for the urine and albumin. Okay, simultaneously you have to catheterize the patient and check the level amount of the urine output, so that based on that you can start the IV fluids. Okay, so here intravenous line is started, and you prefer the starting with the ringer lactate. Now the main problem here is that this patient are at risk of developing the pulmonary edema, so you have to you have to start the IV drip in such a way that it should not create the volume overload in such kind of patients, as well as it should hydrate the patient sufficiently. Okay, so how are you going to decide? So based on the urine output, you just add 1 more liter of the fluid. So this is going to be the fluid requirement which is given to the patient. Okay, so that much amount of the IV fluid should be given to the patient. Next, you are going to monitor. So once that basic management is done, you are going to assess the quick upper respiratory tract assessment, airway breathing, and then you are going to maintain circulation with the help of the IV line. Next, you are going to go for assessment of the vitals, which includes the temperature, pulse, respiratory rate, as well as the blood pressure. Okay, and this is to be done reassessed every half hourly, if needed earlier. SpO2 levels are going to be checked, and also simultaneously you go for checking the fetal heart sound. Okay, so this was the initial general management. Now once this patient is generalized, stabilized, then and then only you go for the obstetrical examination, that is examination of the per abdomen, lie, attitude of the fetus, as well as checking whether the patient is in labor. You going for per, so that is done only when the patient has been initially stabilized. Okay, so once that is done, based on which you can even call for the per op, or inside the labor you can call the radiologist to give us the ultrasound of the patient. Now once this general management is done, you go for next immediate simultaneous step is going to be giving the magnesium sulfate to the patient, so that the further episode of the seizure does not take place, or if the patient is still having the episode of seizure, then you can control the seizures. So here in case of pregnancy, the magical drug we have is the magnesium sulfate. Okay, so this is the main line of the drug for the, it is going to be the main line of drug for the control of the seizures. So here how it is going to go and act. So the mechanism of action is, it is going to cause the reduce the presynaptic release. Okay, so presynaptic release, so let's consider this as a neuron. Okay, so here it is going to presynaptically inhibit the release of the neurotransmitter, which is the glutamate. Okay, also it blocks the glutaminergic NMDA receptors. Next, it is going to cause the enhancement of the adenosine action, and lastly it causes the mitochondrial calcium buffering action, and it is going to block the calcium entry through the voltage gated channels. Okay, so you have to remember that this also acts on the calcium channels, so therefore it has to be avoided using the with the another calcium channel blockers like the nifedipine. Okay, so this is about the mechanism of the action of the magnesium sulfate. Now if you are going to give this magnesium sulfate to the patient, it is going to produce a large number of the side effects. The main action along with that, it is also going to cause, because of the calcium channel blocking, it is also going to cause the slight amount of the vasodilatation, and as a result of which a slight fall in the blood pressure might also be seen, which is with the magnesium sulfate. Now what happens is, because of this kind of vasodilatation, the patient is also going to experience slight amount of the warmth, as well as flushing, as well as tingling sensation when you are going to give the magnesium sulfate to the patient. Simultaneously, patient would also experience nausea and vomiting, and these calcium channels are going to be blocked in the muscles of the skeletal muscle as well. So patient is going to experience the muscle weakness, as well as there is a risk of the respiratory depression and the diplopia in the patient. Okay, so that was about the side effect profile and the mechanism of action. Now how are you going to give such a drug? So basically magnesium sulfate, it is available in the form of the ampule. Okay, form of the ampule, and each of these ampule is going to contain the market preparations which are available. They are anyways going to contain a diluted form of the magnesium sulfate, which is 50%, and it is going to contain 1 gram per ml. Okay, so 1 gram per ml amount of the magnesium sulfate is present. So in each ml you have around roughly 500 milligrams. So if whenever you are going to give such a regime, you have 3 different regimes which are available, which is going to be the Pitchard's regime, Zuspan regime, as well as for Indian population you have the Dhaka regime. So here you don't need to mug this up, just understand this. So in case of the both of these regimes, what you have is the initial, which is going to be the loading dose. That is, you are going to load particular magnesium sulfate drug inside the mother's body, because why? Magnesium is one of the iron which is present, so it undergoes rapid redistribution. So once that is given, you are going to load it inside the mother's body, and then because of the rapid redistribution as well as its excretion to the kidney, you require to go for the maintenance dose. Okay, so because it is rapidly excreted as well as from the kidney, just you have to maintain the dose. So how you are going to give it? So here pit charts is the one which is a combination of the IV plus IM. Okay, just remember it, do not need to mug up. Pit charts is going to be IV plus it is going to be IM, whereas Zuspan is going to be only and only IV. Okay, so what you do need to do is you have to have 4 grams of the IV dose. So you are not going to give it straight away. This IV dose, anytime whenever you're going to give such kind of a drug to the patient, you just have to dilute it because it is going to be very toxic to the mother's body. Okay, so it is going to cause large number of the irritation as well as the vasodilation warmth to the patient. So what you need to do is take 2 ampules. Okay, so 2 ampules plus 2 ampules. Okay, you take a 10 cc of the syringe and you fill the drug of this 2 ampules into one syringe and these 2 ampules in the other syringe. Okay, so what happens is you have totally 4 ampules of the drugs which will be given for the IV solution. So what you need to remember is that in each ampule it is going to contain 1 gram of the drug, but there are 2 ml in each ampule. Okay, so this is because it is going to be a 50% diluted solution. So what happens with this, total 4 ampules are given intravenously and you have 2 ampules which each containing around 2 ml, or it has basically 2 grams of the drug. So 4 ml of the drug plus you have to dilute it with the normal saline which is of the 6 ml. So in the one syringe which contains the 10 cc. Similarly, you take other 2 ampules where you are going to go for 4 ml of the drug which contains 2 grams of the drug, plus you are going to go for the 6 ml of the normal saline. Again you dilute it. Okay, and this is going to contain in the second 10 cc syringe. Okay, this whole combination, so total 2 10 cc syringe which is containing only 20%, you are diluting it to such an extent that 20%. So 1/5 is going to be the drug and the rest 4/5 is going to be the normal saline. So you are diluting it and it is going to be given slowly over 5 minutes. Okay, so that is the loading dose in the case of the Pritchard's regimen. Again, the same is the loading dose of the intravenous in the case of the Zuspan's regimen. It is given very slowly over the period of 5 to 10 minutes. Okay, now the only difference between the Pritchard's regimen as in the Zuspan is that for the maintenance dose you have to give the intramuscular thing in the case of the Pritchard's regimen, whereas Zuspan you directly switch over to the maintenance dose, okay, which is given intravenously diluted version. So for the IM amount or how it is to be given in the case of the Pritchard's regimen is you take total, again you are going to take, so here you had taken 4 ampules which were already used. Now rest you have is the you require other 5 grams for the right buttock and you require 5 grams for the left buttock. Okay, this is given in the 50% diluted form. Now this already the commercial preparations which are available, they are going to be 50% diluted form and therefore you do not need to further dilute it. You just have to break 5 ampules and these are going to contain 5 grams of the drug, give it in one buttock and then second you give it in the other buttock. So that is total 4 plus here you have total 10 of the drug. So total 14 ampules of the drug would be used if you are going to use for the Pritchard's regime. Okay, and then for the maintenance dose you are going to repeat in each buttock alternately every 4 hours the same dose, which is going to be 5 grams IM in the 50% diluted form. Okay, so that was about the Pritchard's regimen, regime containing both the IV as well as the IM sources. Now in case of Zuspan, you have just the intravenous load. As I mentioned, the loading dose is going to be the 4 grams 20%, which is given slowly over 5 minutes, and it has to be immediately started with the maintenance dose where you go for 1 gram per hour in a infusion form, and that this is going to be a diluted form, which is going to be 50%. Okay, so this is given in the pint, and you go give it with the dial flow. Now for Indian populations, what happens is, so initially, instead of the very high doses, only 10 grams is given, wherein you go for giving 4 grams IV slowly over 15 minutes, followed by, instead of the 5 grams which you were giving, you just reduce the dose to the 3 grams, because Indians are going to have a smaller body stature. So this was actually, the 5 gram was for the Western population, but this has been changed, which is called as the Dhaka regime. And then instead of 5 grams for the maintenance dose, you are only going to give 2.5 grams IM. Okay, for the first 4 hours, every alternate buttock, till the until 24 hours of the first dose has been completed. Now, till when are you going to continue such kind of a drug? So, stoppage of drug is done when? Once the delivery takes place. After that, you have to go for continuing this drug till 24 hours, or even after delivery, if the patient had an episode of fit. Okay, so let's consider the patient had episode of fit after 4 hours. So after the episode of the fit, you have to consider that it should be continued for 24 hours. So whichever is later, you have to continue till that duration, either the fit or the delivery, whichever is later, continue till 24 hours of that thing. Okay, once that is done, you have to go for monitoring. Okay, so once the magnesium sulfate is given, so you need to remember that this is one of those drugs which is going to have a very low therapeutic range, and therefore you have to consider the monitoring, because if it is not properly monitored, the patient will be developing that signs of toxicity. So before initiating the drug, always check for the SpO2. Okay, also you need to check for the knee jerk, which is going to be the deep tendon reflex. Then you have the urine output and respiratory rate. Now you need to understand that whenever the magnesium sulfate is given, the source of excretion is going to be kidney, and therefore while initiating, you should have, at least the patient should have the urine output of more than 30 ml per hour, or in 4 hours at least 100 ml. Okay, so if the renal failure is there, you have to reduce the dose of the drug. Okay, so in case of the renal failure, if the creatinine value is going to be more than 1.2 milligram per deciliter, just give the loading dose as it is. But for the maintenance dose, you have to reduce the quantity of maintenance dose, and then you have to monitor the serum level of the magnesium. Okay, so that was about the renal relation with the magnesium sulfate. Now if you talk about the toxicities which are seen, so why are we actually monitoring these? So we have different kinds of the toxicities which are produced at different therapeutic levels. So if you consider at if the levels of the magnesium is going to be between 4 to 7 milliequivalent per liter, this is going to be the therapeutic level which is going to prevent the development of eclampsia. But if it increases to 10 milliequivalent per liter, then that produces the depression of the deep tendon reflexes, that is the patella reflex is going to get lost. Okay, if the levels are going to still further increase, what happens is it leads to respiratory depression. And lastly, if the values are going to be very high, up to 25 to 30 milliequivalent per liter, what happens is it is going to produce the cardiac arrest. Okay, so patient might also complain of the doubling of the vision as well as slurring of the speech. So that is the reason why you have to strictly monitor the urine output as well as deep tendon reflexes, measure SpO2 and the respiratory rate before giving the such kind of a drug. Okay, now consider that suppose it is given, okay, and the patient develops, along with that simultaneously patient develops renal failure, or somehow the patient is going to have the development of toxicity. So we have a drug, we all know that this is going to go and act on the calcium channel as well. So you have to give the calcium excess in the body, which is given by the calcium gluconate, which is the 10% of the calcium gluconate is given as 1 gram in 10 ml of the syringe slowly over 3 minutes. Okay, this acts as the antidote, and simultaneously you also need to give the SpO2 monitoring. If that is done, what also you need to do is, if required, the additional mechanical ventilatory support can be provided to the patient. Okay, But another thing you need to remember that this magnesium sulfate is going to go and act on the calcium channel blockers, and therefore never ever combine with the nifedipine, because there is a theoretical risk of the sudden development of the hypotension. Okay, so sudden hypotension can develop in such patients because of the vasodilatation. Okay. Apart from the magnesium sulfate, there are other drugs which are also can be used in for the anticonvulsant, and we have here is the phenytoin, which is going to be the second line of agent. It inhibits the spread of the seizures, and here it is given in the loading dose, which is going to be 1 gram is diluted in 200 ml of the normal saline, and it is given slowly over 20 minutes. That is going to be the loading dose, and then followed by the 100 milligrams in 200 ml of saline, and this is given 6 hourly. Okay. The side effect which is going to be seen with the case of the phenytoin is that it is going to be bit toxic, which is going to cause the sudden respiratory depression. It can lead to lethargy, it can lead to cardiac toxicity, as well as hypotension, as well as development of the ataxia. Okay. Diazepam is actually not used, but previously it was used. You have another term which is called as glytic cocktail, as well as the Menon's regime. Now it is also not used, but you need to remember that it consists of the 3 drugs, which includes the promethazine, it includes pethidine, as well as the chlorpromazine. Okay, and lastly you can use the midazolam if there is uncontrolled convulsions. Okay. The next part of the management is going to be controlling simultaneously the blood pressure. The aim of the management is to keep the diastolic blood pressure to a lower range, that is about 90 to 100 mmHg. Okay, so that should be the aim, and for that we have various intravenous regimes, which is going to be the labetalol. You can also use nifedipine, which is given orally. Okay, or you can use hydralazine. More commonly what is used is the labetalol. Okay, so I had talked about this is going to be combined alpha plus beta blocker, and I have discussed about these antihypertensive in the part 1 of this chapter. Okay, so simultaneously correcting the blood pressure or controlling the blood pressure is very important. Lastly, we have in such a patient, we all should know that the main culprit is going to be the placenta. So delivery is to be carried out as soon as the patient is going to have the fits in case of the antenatal patient, and this step is going to get omitted if the patient has already been delivered or she is during the process of the labor. So here decision to the delivery should be taken as soon as once the patient is stabilized. If you're going to delay, so what happens is there is a dilemma that okay, fetus is not yet matured, but the mother had history of the conversion. For the fetal maturity, if you are trying to prolong the pregnancy, that is mere foolishness. Okay, so because the second episode the patient is going to have worsening of the cerebral functions and all that, and you're putting the life of the mother into unnecessary danger, so just avoid that. Also, you need to know that because during the episode of the seizures, what happens is the body is going to experience the tonic convulsion. So uterine muscles are also going to undergo sudden contraction, and because of that, most of the times the labor is going to start spontaneously. But if it is not yet started, you can go for induction of the labor using the prostaglandin jets, or you can go for the oxytocin. Okay, so prostaglandins can be used. Now, most of the times vaginal delivery is the preferred mode of the delivery. Okay, and the delivery within 4 hours of the stabilization is and something which is ideal. But there are certain indications where you have to go for cesarean section, majority of which is going to be the other obstetric indication which require that okay, the normal delivery cannot take place in such conditions, and that is where you are going to go for cesarean section. So such as there is cephalopelvic disproportion, or there is abnormal lie, or placenta previa. Okay. Apart from that, if you talk about associated complications, that either is going to be associated with the diabetes, or she is going to be the elderly primary gravida, where you require the good perinatal outcome as well. Okay, or the mother's condition is rapidly worsening, so she cannot sustain to such kind of the stress of the labor. So then in that condition you have to go for cesarean section. Or if the fetal monitoring is not possible, or there are no means of the vaginal delivery that might be possible in the given duration. Okay. you may have to go for emergency cesarean section in the cases like is the development of the sudden development of the fetal distress or sudden worsening of the maternal condition, or if you decided that the patient will be undergoing the normal labor but there is failure to progress, or if there is the hepatic capsular distension. Okay, all these are the indications of the cesarean section. Now, in case of the second stage, if the patient is undergoing the vaginal birth, then there is a tendency to cut short the second stage of the labor once the full dilatation of the cervix has been occurred and the station has crossed zero. Then you can go for application of the forceps or the vacuum delivery. Okay. Once the delivery of the baby takes place, never ever give ergometrin. Okay, just always prefer oxytocin, which is given 10 units IM, or it can be given as a concentrated IV drip. Once the patient has been delivered, you have to manage the puparium and you have to go for regular monitoring of the blood pressure in the postpartum period. Give her antihypertensive medications and ask her daily, at least twice daily, about any signs and symptoms of the preeclampsia, imminent eclampsia she is experiencing. Apart from that, you have to also go for the again investigating all her blood investigations, daily checking for proteinuria, and she should be followed up again once she is discharged. She should be followed after 6 weeks again to check whether BP has returned to normal or not, as well as the proteinuria has been resolved or not. Okay, if it is still persisting, that is the patient is going to have high blood pressure as well as she might have persistence of the proteinuria, then you have to refer the patient to the physician. So that was all about the eclampsia, which is one of the component of the hypertensive disorders of the pregnancy, which you see as a complication of the preeclampsia. And we talked about how it is taking place, what are the types of the eclamptic fits, whether it is antenatal, intrapartum or the postpartum, then what are the reasons why it is taking place, and what is the etiopathogenesis once it is occurring, what you are going to do in such a patient, how you are going to manage such a case by stabilizing the patient, giving the anticonvulsant agent, which is going to be magnesium sulfate, simultaneously controlling the blood pressure and plan for the delivery of the baby. Okay, so that was about the eclampsia. Next we talk about is the certain one-liners, which is the most common type of eclampsia, which is going to be the antepartum eclampsia. What is the one with the worst prognosis? Again, it is going to be antepartum eclampsia. Why? Because the perinatal mortality is associated with this to as high as 45%. Okay. What are the factors which are going to determine that, okay, so this is going to have a good outcome or the bad outcome in the case of the eclampsia? So this is mainly the duration of the period of gestation of the eclampsia. The longer the patient stays in the FITS form, the worse is going to be the prognosis. Also, there are brain changes, and these brain changes are going to get detected on MRI. And what will you find? So you're going to find the subcortical white matter edema, which is taking place. And one of the major causes of the death in such kind of patient is going to be the intracranial bleeding. Okay. So that was about the eclampsia. It's one-liners. Next, we move on to the next spectrum of the hypertensive disorders of the pregnancy, which is going to be the chronic hypertension. Okay, so what do you mean by chronic hypertension? So this is also a term which is similar to that of the essential hypertension, what all of the students study in the medicine. Okay, so here if you consider the timeline, if the patient is diagnosed having blood pressure which is going to be more than 140 systolic or diastolic, which is going to be more than 90 mmHg. Now, if she is diagnosed to be having such kind of hypertension, but before the 20 weeks of gestation, okay, before 20 weeks of gestation, mind well, always rule out the HMOL in such cases, okay, or she got pregnant, but before pregnancy also she was already a known case of the hypertension with taking the antihypertensive medications. So in all these cases, this is going to be called as the chronic hypertension. Apart from that, the second clause is that here at this point patient had delivery. Okay, after delivery, after the development of the 3 weeks postpartum, even after that she has the raised blood pressure, then in such conditions you will be considering it as the chronic hypertension. Okay, so persistence of the BP beyond delivery, beyond the 12 weeks or the 3 months of the delivery, that is going to be called as the chronic hypertension. Now, there are different kinds of the hypertension. So we have certain causes because of which the hypertension takes place, which is because the secondary to that cause, which is a part of the secondary hypertension, which includes only 10% of the cases, whereas the rest is majority is going to be the primary hypertension, which is 90% of the cases. Now, if you talk about the secondary hypertension, then what are the organs? So most importantly, either it is because of some kind of endocrinology, or because of the renal diseases, or because of some kind of autoimmune disorders, or because of the obesity. So if you talk, most common is going to be obesity, or that could be because of the coarctation of aorta. Okay, next you have is the collagen vascular disease, mainly the medical disorders like the systemic lupus erythematosus or the scleroderma. Okay, next you have because of some kind of endocrinopathies which is seen in the patient, maybe having the primary hyperaldosteronism because of water retention or the thyrotoxicosis, or patient might be having Cushing's syndrome, or even acromegaly or pheochromocytoma. So all these are going to cause the secondary hypertension because of the secondary chronic hypertension because of the endocrinological disorders. Okay, next you have the renal disorders. So renal disorders includes what? So this may include the development, patient might be having the history of the acute or chronic glomerulonephritis, or patient has polycystic kidney disease, or there might be history of the interstitial nephritis in such patients, or patient even has some kind of the renovascular disorders, or patient had the history of renal failure. So all these may predispose to development of the secondary hypertension, and this is in pregnancy called as the chronic hypertension in pregnancy. Now, because of these, what happens, the mother and the fetus, they are going to be actually at a risk of lot of complications. Now you need to understand, before proceeding to complication, what happens is, I'll tell you one thing, that because these patients are going to have pre-existing hypertension. Now consider this female, she was not going to get pregnant. Okay, in long term, consider that after 15 to 20 years, so she develops the hypertension at this stage. Okay, let's say at the age of 25 years she was diagnosed to have hypertension. Now she will be, because of the development of hypertension, whenever she is going to reach her 50 years of age, she will be having large amount of the complications because of the hypertension, mainly the renal complications. Okay, or she might have the cardiovascular complications. Okay, atherosclerosis, or she might have the CNS complications, or even the retinopathy. Okay, now in her timeline, what happens is, at this particular stage, let's say at the age of 31 years, she becomes pregnant. Okay, so what happens is, all these complications were, if she was not getting pregnant, what happens is these complications are going to take place at the age of 50 years. But because of the interruption of these by a pregnancy, what happens, this pregnancy is going to cause the rapid progression of these complications, and with pregnancy she will start experiencing these complications during her pregnancy. Okay, so this will cause the worsening or the acceleration of these complications which were destined to occur in a patient of the hypertension later in the life. It takes place whenever the pregnancy is occurring, because it is a stage of the lot of physiological changes or acids taking place in the pregnancy. So in the mother, what you're going to experience, or the patient is going to experience, is the abruption risk, the risk of superimposed preeclampsia, that is along with the just increase in the chronic hypertension. Patient will also have the renal failure, and there is proteinuria which is seen, plus there is risk of the other end organ damage. Okay, so this is going to be called as the superimposed preeclampsia. Patient might even have the malignant hypertension which might not be controlled. Patient may experience the congestive cardiac failure as well as the renal damage. Okay, so all these complications which you see normally at a later age of life are getting accelerated and present during the pregnancy. Okay, in the fetus, the fetus might have the blood supply to the fetus might be compromised, leading to the abortion or the fetal growth restriction or intrauterine death, and might be you have to terminate the pregnancy prematurely, leading to the prematurity. Okay, so for managing such a case, most of the patients, what happens is, they might be a known case of the hypertension and might be taking some kind of medication. So during the preconceptional period, whenever she comes to you for seeking the advice that okay, is it advisable to to conceive a pregnancy or not, you have to fully explain her that okay, you can conceive the pregnancy, but there are due risks to your own life as well as to the life of the baby you are going to have. So once that is done, if she is ready for the conceiving the pregnancy, then you have to shift her from medications which she was taking. So change the medications which she was taking. So most of the times patients are going to take the ACE inhibitors or angiotensin receptor blockers. Okay, so you have to strongly, you do not need to give this because they are going to have the teratogenic effect. Simply change it to labetalol. Okay, also you can give the nifedipine to the patient, okay, or methyl dopa. So these are the drugs you are going to give in such a patient. You have to take the history in detail of such a patient, and once she is either she is diagnosed during the pregnancy before 20 weeks of gestation, you have to take for detailed history. You have to go for examination of such patient, and in investigation, the investigation profile is going to be similar to any case of the hypertension, such as you go for the CBC, you go for the level, checking the level of the platelets, you go for the liver function test which includes the SGPT, SGOT. Okay, you go for checking the level of the creatinine, you go for checking the level of the blood urea nitrogen, the electrolytes, urine albumin. Okay, along with that you have to also go for the fundus examination, ECG, echo of the patient. Okay, so this needs to be done. Along with that, fetal investigations are also to be done, where you go for the NST, you go for the USG which includes the Liker, okay, fetal growth, okay, and you have to go for the Doppler. So all these things needs to be done for the surveillance and management. Okay, so once that is done, during pregnancy, so you have to check whether her blood pressure is falling into a normal range or a high range. So if the blood pressure is with the antihypertensive medication is going to be maintained to 140 to 170 systolic, okay, or diastolic is maintained between 90 to 109 mmHg, it is called as the low risk group. Okay, whereas if the BP is going to be very high, which is going to be more than 170 to 110, then you have to counsel her that this is going to form the high risk group. Okay, so this forms the high risk group. Okay, so in case of low risk group, what you need to go is you can go for safely continuing the pregnancy with explaining the patient about all the complications which can occur and regularly monitoring, okay, that these are the signs. Current investigation is going to be normal, but you have to go for repeated investigations and detect that whether the superimposed preeclampsia is developing or fetal growth is getting compromised or not. Okay, if anything does not happen and all the investigations and the blood pressure would be in the normal range, you can safely go for continuation of the pregnancy and plan for the normal vaginal delivery. Okay, but if at any time what happens is there is development of the superimposed preeclampsia or there is development of the fetal growth restriction, simply manage it like a preeclampsia case and go for termination in case of the worsening of the maternal condition. Okay, if the BP is in very high range, you have to admit such a patient, you have to start antihypertensive medication which includes the methyl dopa or labetalol or nifedipine. Okay, and manage it like as it is a case of the preeclampsia, and based on that you go for the monitoring and the surveillance of the maternal organs and the profile, as well as you go for the fetal monitoring and profile. And if at all the worsening of organs is taking place, just go for termination of the pregnancy. So that was all about the chronic hypertension. So we in the part 2 of the hypertensive disorders of the pregnancy, we discussed about the eclampsia and how you are going to manage the chronic hypertension. So we discussed about what is the definition of chronic hypertension, what are the causes of the hypertension, and lastly we talked about what are complications which can take place in such a cases. You have to change the drug in such a cases if the patient is already pre-existingly taking some kind of the angiotensin receptor blockers or the ACE inhibitors. And lastly, during pregnancy, how you are going to manage such a case. So that was about the hypertensive disorders of the pregnancy. I hope you students understood. Thank you.